sign on, but we should be pretty close. So good morning, everybody. Thank you for joining. I know yesterday was a pretty solemn day around the world and especially here in New York. I hope everyone was able to, take a moment for yourselves, for your families, for those around you, and for all the great work everyone does, and realize that, it's amazing that it's 21 years ago, first and foremost for me, but what a day. So I want to start this morning, Bill, do you want to do a roll call? Is it easier for you to do a roll call, or how do you think?
Yeah, I think that would be the best way. That way we get it on the record, if you don't
Okay,
mind.
so why don't you go ahead and start that?
Okay, I spoke with Mark earlier. He said that he might not be able to make the meeting because he had a problem in the ER. So I know he was at the early meeting, but I don't think he's going to make this one. Okay, so, Dr. Arshad.
Good morning, team.
Ha.
Dr. Larson. Dr. Stubmiller. Dr. Brutus. Dr. DeCosard. Dr. McKinley. Dr. Wasserman. Dr. Chung. Dr. Tovis. Dr. Midori. Dr. Supple. I got a couple, let me just let them in. Dr. Templeton. Dr. Greenhut. Dr. May. Dr. Rowntree. Dr. Ajabani. Dr. Brutus. Dr. Brook. Dr. Cohen. Dr. Cohen.
Yep, I'm here. Yeah.
Dr. Santos. Dr. Kukuza. Dr. Larson.
Here,
Dr.
present.
Okay. Dr. Quintero. Okay, was there anybody else that I called and didn't answer, or she?
This is
Yeah,
the door, so I don't know if you called, but I stepped out for just a moment, so I'm here.
Okay, I did, but we're good, thank you.
yeah, Dr. McGurty, Dr. DeCosard.
Yes. Dr. DeCosard is here.
He's from Catskill. You have Dr. McGurty from Hudson Valley.
Okay.
Any other physicians or members on the line that weren't called, just please speak up so he can put you on the roll call. Thank you.
It gives me 6 then. We need 8.
Okay, so we'll start. We just won't be able to, vote on anything or approve the minutes at this point. But what we'll do is circle back, Bill, because it's still only 9:34. So people
Sure.
could still be calling in. Thank you, everybody, again. So I'll ask you to review the minutes, but we cannot vote on them until we have 2 more people to make a quorum. I did not see any additions, corrections, or deletions. They seemed appropriate to me. Moving on to service upgrades, we have 1 upgrade this morning. Under Northern Dutchess Paramedics, we have an upgrade of a pad. Sorry, under Northern Dutchess, we have the 12 lead EKG, CPAP, Narcan, and glucometry that went into effect July 28th. And under New Vance Medical Health Education, we have a pad site effective July 25th, 2022. Evaluation Subcommittee report, Dr. Arshad.
Hey, good morning, team. We do have a case to review this morning. So call type goes out for a 92-year-old mechanical fall presenting with chest wall pain. Crew is relatively quick to respond, arrive. A paramedic and EMT are on scene, and ultimately the EMT assumes control of the patient. The patient is, again, 92 years old, German speaking, and the history is obtained via her husband, who states that she had a fall several hours earlier, and she's now complaining of left-sided pain and left-sided chest pain and left-sided shoulder pain. They're on scene. They get 2 sets of vital signs on scene, and I'll just read those off quickly. Okay, so vital signs number 1 is 97/45, blood pressure automated with a pulse rate of 86. Heart, and then vital sign set 2, again, this is pre-transport, is 128/74 with a heart rate of 95. The remaining vital signs were all normal. The patient arrives to community hospital, and she's under my care as an attending physician. And just for full disclosure, I'm the one that escalated this case to the evaluation subcommittee. We connect her to the cardiac monitor and find that she is bradycardic to a heart rate of 37, and her systolic blood pressure is in the 80s. So being concerned, we perform a 12 lead EKG and find her to have an inferior wall STEMI with ST elevations in 2, 3, and AVF, and also to be in a 2nd degree heart block. At that point, I sort of started chatting with the husband, and really the questions that I wanted to know first were, hey, did you witness this fall? And his answer to that was, no, I didn't witness it. I heard her sort of fall over from the other room. And then I was curious, I'm like, does she fall in general? Has she been having more falls recently? And he said, no, really, she's never fallen inside of our home ever before. So again, being a little bit more concerned there, we activated, the cath lab from the community hospital, requested the helicopter. She unfortunately had an aspirin allergy, and given the history of the traumatic injury, I needed to scan her. Otherwise, we would have, considered a lytic agent such as TNK, for example. Just then going back through the PCR, the EMT had teched the call and transported it. It was sort of a little bit closer to the community hospital, maybe 5 to 10 extra minutes to the trauma and PCI center. In the PCR, there was some comment on left-sided chest wall tenderness on exam, but not a comprehensive trauma evaluation or cardiac evaluation. Ultimately, right before transfer, she became significantly more hypotensive and required, I started dopamine in terms of chemical pacing, and then transitioned her to transcutaneous pacing prior to the critical care crew arriving. And then ultimately, in the cath lab, was found to have a 100% RCA lesion, sort of explaining the AV nodal dissociation in the bradycardia. And then unfortunately, she passed within 24 hours. So there were some concerns regarding the case. Primarily, you have a paramedic and an EMT that are both responding to the call. Even though the dispatch was for a quote unquote mechanical fall, with a little deeper history taking in a woman who's not English speaking, we were able to uncover that it was certainly more likely to have been a syncopal event. The husband also relayed to us that he had given her 2 tablets of tramadol and the pain had worsened, which is why he called 911. So even in that regard, there's some other clues that would sort of guide us towards ALS management in this case, which ultimately may have gotten her to the correct destination center and may have made a difference in outcome. So I had an opportunity to speak with the QA/QI director at the agency, as well as the agency medical director, and they are going to be planning a meeting with the crew sometime this week. And I'll just take a quick break there and open it up to see if there's any questions. And then I know the committee also evaluated the case, and we have some anonymous reviews that Bill will share a little bit later on too.
Was there a 12 lead that was done in the field?
No, there was no, unfortunately, no 12 lead EKG was done. There was no documentation by the paramedic regarding an evaluation. Even like a 3 lead or a 4 lead was not done. No cardiorespiratory physical exam was also not documented.
So that's a problem right into itself.
The other thing I brought up this morning, because I was on the evaluation committee meeting, was you have an elderly female, even if the history is a fall and she, hit her chest, hit her shoulder or whatever, that first blood pressure was so hypotensive. One, should it have been reevaluated with a manual reading, and 2, repeated more than once? Because why was she hypotensive? If it's trauma, then do you think about that she has blood loss? Versus, we're not getting an accurate history, whether it be the communication with the wife since she speaks only German versus that she didn't fall and it was an acute MI and hypotensive with the inferior wall involvement, the right RCA. So the other thing was, Dr. Ashad, you had a couple of blinded reviewers also.
Yeah, I think Bill is actually trying to speak, but muted.
Yes.
I think Bill is actually trying to speak, but muted.
We did have a couple of independent people take a look at the PCR. It was a blind review just to get their input on, one was an EMT and one was a paramedic, and they came out with very similar things. Why wasn't an EKG done? Why wasn't the patient reassessed and moved to the hospital? A patient that was under medication should have had an ALS workup on it, and there was none there. Was there any crepitus in the rib area? And why were there no additional vital signs taken in route to the hospital? So it was pretty much the same thing that we talked about at the evaluation committee this morning.
There was some cutting in and out, so I might have missed some of that presentation, but what I understand is you were working at not a tertiary care center or medical center, you were at a community ED at the time. Is that correct?
Yes, ma'am. Yes, ma'am.
Okay, and so the EKG aside, it does sound like they did vitals and then repeated vitals. Is that right, with an improved blood pressure?
Yeah, I can actually give you the timing so it's clear. So
And the heart rate times
yeah,
was,
absolutely. So dispatch goes out at 2300, crews en route 2303. They're on scene at 2309. So they're within 7 minutes. They're on scene for 20 minutes. Both sets of vital signs are done while on scene.
okay.
And then
then
it
how-
takes a 20-minute transport. There's no documentation of a reassessment and no repeat vital signs. And she arrives with a heart rate of 37.
Okay.
We're giving some feedback, so if anybody's not speaking, could they please mute? It seems like we're getting some feedback from somebody.
Had an EKG been done that showed a STEMI, what would that crew have done differently? Would they have gone to a different center? Were they, too far out to do that? What would you anticipate would have been their course of action had they gotten that EKG while on scene?
Hey, Jeff, do you care to answer that? I know you have some additional insights as well.
Sure. I believe that if they had done a 12 lead initially within the first, preferably 10 minutes of the call, they could have transported to either Vassar or Mid-Hudson Regional in about the same amount of time that it took them to get to Sharon, if not a little quicker, because they wouldn't have to use all the back roads that you would use to get to Sharon. firmly believe that that lack of history and physical within the first few minutes made a big difference.
And also the patient asked to go to Sharon, we would have had to have told her, you can't go there. You need to go to a higher level of care, and had that discussion with her and her husband at the time.
Right.
So the level of care seemed appropriate given the exam and the history that was obtained in real time in that second set of vitals and the lack of an EKG. I guess in that context, it seemed appropriate, just needed a bit more information up front to have made a different decision. And what's the capacity of the EMS crews to communicate with a non-English speaker? Is that entirely dependent on the language skills of the folks there, or do they have other resources that can assist them?
I'm not sure I can speak to the general question, but in our particular scenario, the husband was doing the direct translation, which is always suboptimal. You want to be able to speak to the patient directly. But in this case, the husband was primarily English speaking, was translating everything, was on scene and giving the history and supporting support crew as well as.
And that's how you obtained the history on arrival?
Yeah.
Gotcha.
That's correct. Yeah. Yeah.
I can answer, Dr. Ashad, if you'd like, for the pre-hospital side. There's a lot of opportunity for translation given the technology available and the system that you're on, but it's very, very limited as well. So in Dutchess County, we have the ability to speak through a program through our dispatch center in an emergent way to communicate with folks by a translation line. It's also sort of suboptimal, and depending on the crew and their availability with Wi-Fi and their phone signal, there's Google Translate, which is sometimes helpful, but those are also fairly lacking in sometimes situations like this. So it is super tough if you don't have the resources available. There are some, but they are limited.
Here, Dr. DeCosta here. A quick assessment is that for anybody, whether it's EMS or us in the hospital, we always have to remember that any falls in a geriatric patient is to be considered as potentially non-mechanical unless described as such by the patient or a witness, and so appropriate measures can be taken. And so I don't know exactly at the place, the hospital where the patient went, for Dr. Fazad is, I don't know whether a CT scan was done of the head to rule out the bleed, and whether for the time for the patient to leave your facility to cath lab, was it non-optimal for thrombolytics to be considered? I don't know.
Yeah, great questions, and something that I was considering. So just to summarize, yeah, I received her in the community hospital, but I also work clinically in the tertiary hospital. So when she arrived to me, the presentation or sign out that I received was, this is a trauma case, but we immediately discovered that in fact she's having a STEMI. She had an allergy to aspirin, and then because of the traumatic injury, normally I would have administered TNK, but she needed to get the PAN scan. So she went for PAN scan, and we had called for the flight crew. So once she returned, the CT head was negative. She started heparinization. We didn't have the remainder of the reads. The flight crew came, we started transcutaneous pacing, and then she flew over. So there was not an opportunity in this particular patient to administer a lytic agent. And she unfortunately had a continued infarction, which was obviously a very comorbid situation.
Thank you.
I'm sorry, I missed it. So she got heparin, but not after a negative trauma series?
Yeah, because her complaints were primarily related to the chest wall. So, and I need to know that there's no splenic injury, no rib fractures, etc. before I administer lytic agent. That's a much higher index of suspicion
sorry,
because she comes.
You got that trauma series at the community hospital and she had
Yeah.
no.
But I did not have the
internal
read at that time. Yeah.
read. Gotcha.
So this is Eric Larson. So a couple comments. So just, look, as far as the EMS crew is probably, obviously in this age group, fall is a very common complaint, probably one of their most common complaints that they respond to. So easy to go down that garden path. There were a number of, there certainly were a number of red flags here that should have led them to look at some other stuff. There is the translation issue, but to get these secondary services of translation is obviously both time consuming and less than optimal, depending on, all the electronic, problems that may occur with it. But there was an adequate history here, I think, enough from both the husband and also just the circumstance. I think, this is a big educational process. It often happens we get led down a garden path by something that usually, is straightforward. It is a trauma, but in this case, it really wasn't. There may have been some trauma issues. There may have been a fall, that kind of stuff. So I think, I'm not sure what we want to accomplish with this, but I think certainly it is a chance both to educate that particular crew and maybe other fellow members in their corps, as to be not to be led down the garden path just because of the sort of straightforwardness and the frequency of falls in the elderly. That's my comments.
Yeah, I think this is just anchoring and we all do it and we all kind of, I'm sure we all have examples in which we have done something similar and you head down a path with too little information and it's hard to kind of get off that path. I hope the crew stuck around. I think the best way, they're imperfect just as the rest of us are imperfect, but I find the best learning is when you realize this might have been treated differently at the scene, is to ask them to stick around or invite them to stick around so that they get the benefit of seeing what additional information was gathered and how that changes things. And I think it seems to be a good way to educate them because they realize, I'm sure they realize pretty quickly once an EKG was performed that this was a more complicated scenario than they had initially assessed it as.
And I think, clearly, as you said, we've all been in that trap of, I've done many QA cases here where a patient gets admitted with a diagnosis, and as the days go, clearly we missed the original diagnosis, but we kept that same original diagnosis, constipation, UTI, and the person, had an acute abdomen. So yeah, I think we always have to revisit. Luckily, Dr. Ashad did that rather quickly because I've seen it go, as you said, Dr. Mador, that it keeps going and going and going and not interrupted to really take a fresh look at it.
Yeah, and I think too, if both a paramedic and an EMT are responding, certainly just maintain a degree of suspicion. Take a thorough history, because if you push on the history, all the answers are there to raise your suspicion. As Dr. Larson said, there were numerous red flags. So not making assumptions, certainly in a 92-year-old non-English speaker, maintain that level of suspicion, do your due diligence, take a thorough history, and perform a complete exam. Even if you feel like it's a trauma patient, then the patient should have a documented trauma assessment and trauma exam as well.
Agreed. Any other further comments? Thank you, Dr. Ashad. We haven't had a case and evaluation committee in a while. So we will be moving that case along and following back up with you after the further investigation is done. And thank you everyone for this morning. Next on the agenda is the DOH enforcement reports. And the notifications I have here, a few. Caitlin Amy from Liverpool, New York, was suspended for 1 year effective June of 2022. And for a problem with a civil penalty assessed $2,000. Joshua Feldman from Staten Island, New York, was suspended for 1 year effective in August and placed on 3 years probation, assessed a civil penalty of $500 for a violation of Part 800. Christopher Kitchens out of Eden, New York, was actually had his certification revoked in July for violations, multiple violations in Article 800. And there is a revocation as of July 13th, 2022. Matthew Miller out of Lancaster, New York, was given also a certification had to be surrendered, and he surrendered it as of July 28th, 2022. Again, violation of Part 800. And lastly, Peter Sherman out of North Massapequa, New York, had to surrender his certification in July, assessed a civil penalty of $500 and for multiple violations under Article 800. I've never seen so many revocations of certification till this month. Next is helicopter committee report. Dr. Larson, or would you want to provide that?
Yes. Yeah. Dr. Stu Miller is away, so I chaired the helicopter meeting. Just a short synopsis, just that the helicopters have seen an increase in activity over previous years, especially active during the summer months. A variety of stuff, mostly trauma in terms of scene calls, but also doing a number of scene calls for both cardiac and neuro issues. The biggest thing that folks have noticed, and I'm going to let some of the other members of the committee chime in with actually some numbers and more detail, but a increase of activity of the use of the helicopter to transport people, especially from the central New York area into the Hudson Valley. It seems that the Hudson Valley hospitals in general had better capacity, better staffing, and the sort of specialty services that were necessary, and which were lacking in a lot of the central New York hospitals. So we've had a lot of, and upstate New York hospitals, we've had a lot of fairly long distance transport of critical patients. And so that was really the main thing. There were no particular hot button issues, but I'd like some of the other members of the committee to chime in and add a little bit, because I think this whole thing with, I mean, look, we know the challenges to the EMS system, both nationwide, New York State, and our locality. And because of those things, some of it has boiled over into the air medical world. And I think the good aspect is because of the some of the SAFE Act legislation, people aren't being hung with large air medical bills, which I think is helpful, and people are still getting care. But it's, the fact that the EMS system has been so challenged that air medicine is having to fill in and provide that gap, I think is an important note. But I'll let the other folks chime in.
Good morning, everyone. Like Dr. Larson referenced, we're seeing a lot of longer distance flights coming not just from upstate New York, but even out of state areas into the Hudson Valley. We're seeing a lot of staffing shortages within the hospitals and specialty centers upstate. Not so much that the Hudson Valley is immune from staffing issues, as I'm sure you guys are all very aware, just a lot more flexibility in managing those higher census throughout the local facilities and doing some load balancing activity as we're seeing some more subspecialties pop up at where were once, community hospitals to an extent. It's not uncommon for us to see even cath lab patients coming from the Watertown or, Adirondack region into Kingston or Vassar or the likes recently. With the increase in longer distance missions, we are seeing more activity from our partners at Hackensack coming in and backfilling some of our resources for the area. We're very grateful for that help. And as Dr. Larson mentioned, we are seeing more utilization. Fortunately, it hasn't translated into poor utilization with very few exceptions. I think with some of the stressors of COVID and staffing in general, people have sort of been forced to become more comfortable with the clinical offerings of a helicopter on the critical care side, as well as a decrease in out-of-hospital time. And equally importantly, just resource preservation in some of these communities throughout New York, where we have single-digit paramedic units on for an entire county, if not region, and taking that unit out of play for 8-10 hours for a single patient just isn't good for the community and certainly not good for the patient. And one of the factors that's really helpful along those lines is just, good financial practices. It's not dependent on one single air medical provider. With the No Surprises Act, those are universal changes where we know that those patients are not going to be billed outside of what the insurance company pays, barring the copay and deductible. No one's losing a house. No one's becoming financially burdened by a necessary level of care and speed of transport anymore. Otherwise, we looked at some of the stroke data that was requested from our last meeting. We're seeing close to single-digit transports for neuro patients within the Hudson Valley from our scene flights into local hospitals. The biggest change that we've seen since 2020 is not necessarily volume, but destination. With Mid-Hudson and Vassar coming online with thrombectomy capabilities, we've seen shorter distance flights. In 2020, all the flights went to either Albany or Westchester, depending on the geography and some of the weather circumstances. Whereas in 2022, we're seeing a very even spread amongst the facilities. We had 5 neuro flights into Westchester year to date, 5 into Vassar, 3 into Mid-Hudson, and 2 into Albany. So we're more successful in bringing the patient to the right level of care and keeping them closer to their community and their family when feasible. And that's all I have for the group, unless anyone has any questions.
So I would just like to add one other thing, and that is that, just because of the use of the helicopter, one of the things that's very important that we need to stress among our colleagues is, and EMS crews, whatever, is good documentation as to, be supportive as to why we needed to go to air medicine. These are critical patients. They need critical interventions. We need to put that out there so that there's no second guessing by anyone along the line as to why an air medical resource was used. So I can't emphasize that enough among all of us, that, if you're going to use a helicopter, if a service is going to use a helicopter, if that they need to, that physician needs to really document the critical need for this patient and emphasize that in their reports, their charting, et cetera. That way, there can be no second guessing as to why this patient was sent with a critical asset.
And to piggyback onto that, we're more than happy to have our clinical crews come out, work with your providers to discuss any of those concerns or questions and some best practices. With our flight crews, they're all universally trained in their documentation to be appropriately defensive of those things, whether it's the critical care they require, the pressors, the blood products, the transcutaneous pacing, what have you, the out of hospital time, and even now the availability of ground resources and the potential for prolonged obstruction to the care they need that's time sensitive. All those things are routinely documented on our end, and our patient advocacy group is very effective at making sure that's adequately defended in the event that there's any issues with the insurance coverage.
Yeah, that's really important because, you know, we want to cover the patients, do the right thing. And we don't want them, you know, to have the problem of a bill and it's just because of documentation. So what the two of you bring up is exquisitely important and I appreciate it.
Absolutely. And the last note I'll leave you with on that finance end is, you know, not only is Air Methods started with the patient advocacy several years back and it's been very successful. With the No Surprises Act, it's not up to a single vendor anymore. The federal government has taken on the task of ensuring that everyone's protected universally, no matter which vendor is coming in. So in the event that a patient's transported by Air Medical, it's all treated as in-network insurance, regardless of what the Air Medical vendor has in place. Air Methods, we're about 65, 70% in-network now, the goal being 100 and quickly getting in that direction. But regardless of the work being done on the back end by the vendor, right now when a patient is flown, whatever their insurance pays, that's it. There's no balance billing coming out of that. The only thing the patient is generally accountable for is their copay and deductible. And in New York, we're looking about $200 on average out of that patient's pocket per flight.
And that's really quite outstanding from your organization, to be honest with you. You know, that's impressive. And it just shows your commitment to, you know, patient care in our region and to make sure we get patients to the appropriate destinations in the appropriate timeline. And thank you. Thanks, guys. Anything else to add for Air Medical or you're okay? You're good?
Dr. John McCurdy from Valley, just curious, have you seen a rise in the inappropriate use of your aeromedical assets?
Short answer is no. On occasion, we do see some requests that wouldn't meet the traditional critical care definition. And we've been fortunate in some of the relationships we have with the sending hospitals and 911 providers where we can manage those on one-off basis. If anything, some of it has just been pushing our traditional comfort level, where again, we're having these flights that again, wouldn't immediately come to mind as an air medical activation, but when it's 36, 48 hour windows before that local community hospital can get a ground ambulance to get the patient to the time sensitive care, it sort of changes the calculation and the equation there more so than it would have 3 years ago when we weren't so resource light on the ground.
Thank you very much.
Call in user 2, could you just say your name again? Because I missed it in the beginning and I know you're one of our docs.
It'd be Dr. John McCurdy from Hudson Valley Hospital in Cortland Manor. I'm actually now on this committee for Dr. Chung, representing Dr. Nudovitz.
Thank you. So that provides us with a quorum, guys. So I'm going to go back to the minutes and ask for a motion to accept unless anyone has any comments, concerns, questions, corrections, anything you want to do. Otherwise, I'll ask for a motion to accept.
I'm going to present a motion to accept the previous meeting minutes.
Thank you, Dr. Ashard. Could I have a second, please?
I'll second. It's Evan Cohen, St. Luke's.
Thank you, Dr. Cohen. Great guys, I appreciate it. Next is on to RTAC. And Bill, I don't think there was a meeting, was there? Yeah, I remember seeing the memo that it was delayed or it was postponed, something.
Yeah, I haven't seen anything since then.
Okay. On to quality improvement reports. Jeff.
Still having issues with ESO. The problem is not all of the charts, once they're completed, are reaching our bridge or the state bridge. Data informatics from the state is working on this. Hopefully we'll see some resolution to this. Additionally, we started the back end work for the supraglottic airway and capturing the data that we need for that. We had one meeting last week. We have another meeting today to hopefully tie everything together so that we will be ready when that is able to be rolled out. And that's about it.
I was gonna say, when you brought up informatics, it totally rolled into the update from David. David, would you like to pick up the ball here and run?
Sure, I'm happy to. The iGel was passed unanimously at the last SEMSCO meeting. There was not a CMAC meeting, so you'll see it on the agenda for next week for CMAC SEMSCO. I imagine they'll just discuss it and sort of see where it is and just continue to move forward. In terms of the rest of that process, there is a ton of background work that needs to get done. So the data informatics committee at the state is working on it on their end. Each region will have to work on it on their end as well in terms of being able to get the data in. And each agency are probably going to have to work on it with their particular program. There's something like 20 different EPCR systems out there that each, of course, operate a little bit differently. And so the data that they have has to map appropriately to the region and the state. That'll take some time to do. The state is saying it's going to potentially take 2 months to clear an agency, and so we've provided the state with those agencies that are already interested so they can start to get them online sooner. In terms of training and certification, Ryan Greenberg from the state said, yes, you can absolutely use the statewide learning management system for the education and didactic components and examinations. Agencies are going to have to potentially go to a regional ALS training program for skills verification if they don't have that capacity on their own. And so we're going to work on that piece. And additionally, we're going to have to work on a presentation on how to document an advanced airway according to the NEMSIS requirements for BLS providers. And so there's a few different things we'll have to work out that way. I'm sure we can get that underway fairly easily. Second to last is the data sets and rules that we have to work on. This is, again, all sort of background stuff we're working on with the state and our region to make sure that we're capturing all the right components for the study that we're doing. And finally, to that end, Dr. Arshad and his team are working on the background pieces to get everything together for the study and a paper on the study. These have included so far a literature review, a design study, and outline, and we'll continue to work in getting that through the Hudson Valley so that we can have a good paper on this. Dr. Arshad, do you want to talk any more about that piece of it, or are you good with that?
Sounds great, Dave. Thank you. Yeah, we're excited for the background work and to be the academic sponsor representing the state.
Yeah, it doesn't seem like it up front, but there is a ton of work being done by a lot of people on this project, and it's all going to come together amazingly. So thank you everybody for all of your work and efforts with it. It's a lot of good work. It really is.
That goes back at you, David, because I know how much work you've done. But it's funny that this whole initiative started with this little volunteer agency town of Greenville, which I'm the medical director for. And this thing has snowballed into a statewide process. So it's kind of exciting. But I think everybody was ready for, we have to start upgrading all of our care. And, so it's all good stuff. And we're doing it in a fashion that's safe and with due diligence. Protocol committee, I don't see Michael on the line. David, do you want to talk about, we can kind of blend that into it, like we had that little medical standards subcommittee report and protocol. I don't know if you want, we can just combine it all together.
Yeah, I don't remember if we talked about this the last time, but we had the AEMTs and intubation. It's not in the national scope of practice. And so It's coming out as of January that AEMTs will not be able to intubate. It looks like everybody is really moving towards aligning with the national scope of practice, which is great. Additional things they talked about was GCS and standing orders for RSI. It's currently less than 8. Should it be a required number? The overarching consensus was no, it didn't need to be in there. They talked about oral analgesia and BLS providers, end-tidal CO2 and BLS providers, push dose pressors, and then a pediatric agitation protocol. One sort of final bit is that the SLAMs that we've agreed on, mostly in the lower Hudson Valley, lower part of the state, is that the SLAMs is not in some of the EPCR programs, so it has to be in the narrative. And they're slowly working on getting that into some of those other programs as well. Was there anything else, Pam, that I don't remember off that list?
Yeah, the only thing at the end, we talked a little bit about, or Dr. Daly was talking a little bit about the whole pediatric EC, REMAC, CMAC side of things, and trying to facilitate a process where we work really closely with them. The pediatric subcommittee had submitted a bunch of things they wanted changed, altered, added to the collaborative protocols and to the state. So we're working through those things. It's still in discussion. I'm sure we'll talk about it next week. But yeah, it's the PEDS committee, has some strong beliefs, and, rightly so, it's fine.
Yeah, and so there's no answers to all of these just yet. It'll go through med standards, and then you'll have answers as to decisions of what folks decided to do from there.
So CMAC is next week, the 21st and 22nd, and it is in person in Albany. I screwed that up last meeting, but it's now in person. And they've changed the order a little bit, so just make sure you guys look at the calendar. But it'll be in person.
And this time it's on a Wednesday, Thursday instead of a Tuesday, Wednesday, because the EMS Memorial is on Tuesday.
Okay, thank you, David. Under new business, we reissued the Hudson Valley advisory regarding psychiatric patient destination decisions, just so that everybody gets it out there and communicates it, that, really the pursuant to good care, and what we've always talked about is patients go to the closest facility and get stabilized and medically cleared, then to decide whether someone needs psychiatric admission or can be medically treated and released. But we reissued that, Dr. Papish and myself, back on August 23rd. That's all I have right now. Open forum. Anybody want to bring anything up to discuss?
Dr. Murphy, Rich Parish.
Hi, Rich.
How you doing? On February, September 22nd, there is a 7-county Office of Hospital Emergency Preparedness surge exercise. Every hospital should be aware of it. They should have a representative to that group, but it's a surge exercise, and what it's going to be is a food contamination in all 7 counties. Every hospital is expected to surge to 20% of their capacity, and what they're looking for EMS is when they start offloading their patients to nursing homes or to other facilities, how many resources, how much resources can they supply to do this? I've asked Karen to forward out the documentation on it. All 7 EMS coordinators have been made aware of it. The way it should happen is that you should contact your provider to see what they can provide, and then if that can't happen, then go through your EMS dispatchers so that they can provide you with the numbers. No vehicles, staff will be utilized. It's strictly a tabletop. All 7 coordinators have provided me with their current numbers, and at the time of the call, that's basically all they're going to have to give the call taker so that they can satisfy this requirement. And like I said, I asked Karen to forward out the copy of the documentation for this exercise.
Rich, that was already sent out.
Thank you, Karen. Any questions? Again, your EM person should have made you aware of this. So you know it's
What was
coming.
the date again, Rich?
September 22nd in the morning.
Thank you.
So another thing to add to the agenda this morning, Mr. Grass, do you want to talk about medication shortages and some alternatives?
I'll be happy to, and sorry for, I'll turn my video on there for not problem. Drew McKenzie, who is our logistics coordinator here at Mobile Life, sent an email out the other day. We're finding that we're starting to run low on midazolam. We keep getting delays on the restocks. They keep telling us the end of the month, and that date keeps getting pushed back. Everything from the 1 milligram vials to the 2 milligram vials keep getting pushed back. The alternative, while in the formulary but not in the protocol, is diazepam, but they also are on a extended delay. The question that we wanted to pose to REMAC was, when we run out, what would you like for us to do? And we anticipate that probably being somewhere towards the end of September, beginning of October, if our suppliers do not start restocking us.
So I open, go ahead, Dr. Madore.
I was just going to ask if aside from benzos, I mean, I guess we use benzos for a number of things. What other medications, or do they stock any other anti-epileptics that are non-benzos? That we obviously have alternatives for agitated delirium and other things, but how about for seizure activity?
We'll be happy to investigate what they can get as soon as we get some kind of indication from REMAC of what's going to be allowed to be used.
Yeah, right now, we just have the benzos on there, and actually Valium is, in our formulary, but it's really not part of our protocol. So it is something, I think, boy, I don't know how long ago it was, we said at the collaboratives that we're going to have to allow Liberty to use alternative medications, because the list of medications that were going on the list from across the nation of being short ordered or short in supply was huge, and it was changing like every week. So we were asking that people just substitute within the same category of drug, but this becomes a problem since it's midazolam and Valium, the only two that you guys carry. So we're open to, we can use other things, but I think that we have to, as a group, decide on something we're comfortable with, because we are the ones, unless you want to do it individually with each one of your organizations, but I think it's easier to come from this group as a whole.
Dave, when you're
I
doing that,
think it. This is Eric Larson. I think it has to come from this group.
Agreed.
This is Dave Violante. So, Dave Grass, I'm not sure when you're doing the research if it's possible. I know that we're not able as EMS agencies to purchase from hospitals for pharmaceuticals, but I believe we can for controlled substances. And so that might be a potential avenue to set up a another vendor, as it were, with a hospital and have an agreement with them that's legally you're able to do, that might be a possibility because they have a far greater ability to gather some medications. We're running into issues with other medications, not controlled substances yet, and that's on sort of rotating ongoing basis. And that's certainly state discussions as well. It's happening all over the place. But I agree with Eric, that really's got to come from this group as well.
I'm personally affected by the same critical care shortage when practicing in the hospital. So just as an FYI.
Yeah, I was just going to tell you, David, we're at the same level too, that we had to switch from midazolam to Valium. And now we're seeing the supplies dwindling there also. So I think it's, going to impact everyone. It might be more so that the, pre-hospital guys from the large vendors have problems first. However, I think what we should do is, why don't we try to come up with some kind of alternative so that we can make a process here for you, so it doesn't come to that dire strait at the end of the month.
Dr. Murphy, this is Dave Jensen. Just to add, if it comes from the regional group, it's much easier on us as hospitals to do the QA, QI, rather than having 40 different agencies that have medical directors that give onesies and twosies. It just makes it much cleaner of a review process. But Dave, we're under the same shortfalls as you are.
So we started putting a list together. I'm super happy to forward that to anybody who's interested. The problem we ran into is, since the list changes every day and the medications don't always have the same classification end results that we anticipate and would want, it ends up being really difficult from a standardization of medications and what you're trying to use it for to get what you want, in terms of our guys and gals out on the streets saying, well, what do we have today and what do we not have? And what are the errors with using this over that? And is it approved? Is it not approved? And what's the dose? And I think we're just going to go to the hospital at the end of the day. And so that ends up being some of the challenge. And I was on the phone with one of our pharmacists. We were pulling our hair out trying to figure out what to do. So I'm happy to share that list. If anybody else would want to add on to it or join to it, what we can do, I'll definitely make it available.
I appreciate everybody's help. And as I explained to Dr. Murphy, we're not there yet, but Drew, being as diligent as he is, doesn't wait until we've got 3 days of supply to go, now what? He's thinking, 3 to 4 weeks out. And unfortunately, we're just seeing, delays of, yes, it'll be shipped on the 15th and then the 14th arrives. Nope, it's going to be 10 more days. And we just figured to start this conversation now before it's too late.
Yeah, and I think that's, the premise behind all of this, David, is that, we need to be on the front end. So why don't we do this? Let's have everybody that's a voting member on the committee check back with their institution, see what we have in terms of quantity and availability and resources, and could we help out the pre-hospital arena? I know that from Dr. Ashad and myself, our institutions are challenged with this. However, maybe we could find someone who's not, and then discuss the possibility of even going down the road of, alternative uses, because we don't want to get in a point where we're stuck at the end of the month, David. So I think, over the next week or so, we need to really come up with a solution and a workable algorithm for it.
Just to be super clear, because we went through this with the state a little over a year ago, making sure that we were correct in our presumption of this. Pre-hospital agencies are not allowed to purchase from hospitals unless the hospital has a particular license, seller license, to be able to do so. And although we are able to purchase controlled substances, that's the one allotment. that is out there. So we just have to be careful to make sure we work within those parameters. Because why make it easier?
Just looking for a dealer, that's all.
Hey, you're in Newburgh.
So
No,
I think the first fallback should be to, basically back to Valium because we have it in our formulary, and also certainly the older medical crew, pre-hospital medical crews are familiar with it. And then, so I think we should probably make that provision and transition ready to go, and then think about other, and I just don't know offhand the availability of other benzodiazepines that are, not as optimal, but will certainly suffice. But I don't know if they're any more available than the ones on our formulary.
yeah, I just sent a note to our, our head pharmacist also just to inquire. The other thing that's happening, unfortunately, is that Dr. Larson, the liquid Valium also is on really short order. Like they're running out of that even before we make the switch. So yeah, there's many moving parts, but I agree with you. Valium will be our first alternative, but we're going to have to think of some alternatives because I don't think it's going to be able to take care of the windfall until midazolam comes back, unless something changes.
Dr. Murphy, just so you know, Valium is on our critical shortfall list as well.
And Dr. Murphy, it's also not available to us in the ED at Garnet Health, IV Valium due to shortage.
Yeah,
same
I
thing
mean,
with Ativan. Versed is the only benzodiazepine that we have access to.
yeah, I mean, that's one thing we're going to have to, I think, switch to, Christian, because that's what I was saying before was we're out of it. So I think that, we're going to have to talk about a Versed or some kind of process, in lieu of Ativan and Valium. Why don't we do this? If everyone's in favor, what we can do is I'll take myself, Dr. Ashad, Mark, Dr. Papish, Dr. Spano, you could jump on, and anybody else who wants to jump on, we could do a side call off this and talk about making some kind of ability for Versed to be used in the interim. If we run into that true shortage by the end of the month, we'll at least have a plan, proactive plan in place.
Pam, you'll be able to bring that up to med standards on, okay, wonderful, great.
Yeah, because I don't think we're alone in this. I think it's, really across the country, to be honest. But remind me, David, when they have open forum that I asked that.
Yeah, because I don't know if this ends up being I'm going to try and word this the right way, an operational difference in the Hudson Valley versus a collaborative protocol change.
I'll also
Okay.
reach out to Dr. Daly today just to give him heads up, and Dr. Marshall. I'll put a little email out to him and say, this was the discussion from our committee this morning, and we'll move it forward.
Great, awesome.
I have two quick academic announcements. Awesome. So as many of you know, we started a residency program. I know a lot of you guys are faculty members with your own residency programs in your institutions for emergency medicine specifically. And I just wanted to welcome one of our PGY2s, Dr. Moss, who is currently rotating in East Fishkill on her EMS rotation and is joining us on the REMAC call today. So that's fantastic. And then other exciting news is we actually just submitted last week our fellowship application for the EMS and Disaster Response Fellowship, to be based in the Hudson Valley. So I wanted to both introduce that concept and ask for all of your help. And what I mean by that is, the ultimate goal is to have a physician that's deployable in the Hudson Valley to be an EMS response physician, to be able to do pre-hospital response, obviously direct online medical control, mass gatherings, mass casualties. And we'd like to work with local county dispatchers to help build the physician response matrix too for certain criteria. If you guys have any interesting ideas, would like to help or participate, or even have like staffing needs, like, hey, we always like volunteer at this marathon and we'd love to have some EMS docs there, or even sports medicine docs there. It's a different fellowship we're starting. I would love for you guys to send me a message and to say, hey, we have some cool things, like, could we collaborate? So that we can really make it an asset to the entire Hudson Valley, something that's incredibly valuable for all of us and helps to elevate the care in the region.
Yeah, I mean, I think that's pretty exciting. I will, Dr. Spano's on the line from my institution. He does all the trauma and pre-hospital stuff, so I will hook you two up. But I think that that's exciting news. It also, you know, it comes to the whole thing, Dr. Ashad, of really having a EMS medical director for the whole state, right? We've been talking about this forever, and you know, still trying to push that forward, because I think, you know, we need to have this direct insight and input, you know, as providers in the region, and the availability. So having somebody locally in the Hudson Valley would be fantastic. And I think that, you know, room for discussion. I think it's a great idea.
That's great news, Dr. Ashad. Looking forward to working with you.
Anything else, guys?
Yeah, this is Eric Larson again. Question, what is the status of having in-person meetings? My understanding is that, you know, the emergency, emergency notifications and activations and all those kinds of stuff have come to an end, and that technically we're supposed to be doing these things in person now.
Yeah, so Bill, that was a good thing. I forgot to bring that up. Maybe what we need to do is say that the next meeting, let's see, we are September, so the next meeting is November something, right?
November 7th.
November 7th. Maybe we should move that to an in-person meeting and start back up with the in-person meetings again?
Yes, I believe the executive order expires today. And I don't believe it's going to be renewed, so I think we do have to move to in-person.
So everybody, starting in November, the 7th actually is our next meeting. We will start with in-person meetings at the REMAC office. Thank you again, Dr. Larson, keeping us on task here. Anything else, guys? Sorry. So I will ask for a motion to adjourn.
Hey, I'm going to put forward a motion to adjourn.
Thank you, Dr. Ashad. Could I have a second, please?
I'll second that motion.
Thank you, Dr. Spano. Everybody have a great day. Thank you for joining us. And again, reach out if you have any issues. And again, thank you so much.
Thank you.
Thank you.
Thank you. Have a good night.
Have a good day. Bye.